I'd like to introduce Raoul Orvieto, who's Director in Fertility and IVF Unit at the Sheba Medical Center, Tel HaShamir, and Professor, Department of Obstetrics and Gynecology at Sackler Faculty of Medicine in Tel Aviv, and a good friend. And I've heard him speak on this earlier at the workshop, and it's a wonderful talk. He's going to talk about individualization of ovarian stimulation protocols. Dr. Orvieto.
Chairman, ladies and gentlemen, good afternoon. The title of my presentation will be The Individualization of Ovarian Stimulation Protocol. How do I move these slides?
The big button moves it forward.
There? This one. So I have nothing to disclose. So let's start. Control ovarian hyperstimulation, as you know, is actually the key factor for the success of an IVF cycle, aiming to recruit multiple fertilizable LT oocytes without causing OHSS. And the first question is, what do we mean when we say multiple? So this issue was dealt previously in several studies, one of them from Pasquale, Patrizio, and actually for a more than 70% chance for live birth, we need 15 oocytes, 10 cleaved embryos, or 5 blastocysts. And in order to achieve these numbers or figures, we actually need control ovarian hyperstimulation. And nowadays, we have two main control ovarian hyperstimulation protocols, the long GnRH agonist suppressive protocol and the multiple dose GnRH antagonist protocol, that according to the German registry account for almost 85% of all protocol used. And when we are comparing these two protocols, so you can see, I'm sure that all of you are aware of these slides, that the antagonist is more physiologic, shorter, you need more gonadotropin in the agonist. But the most important question is not whether it's more friendly or less friendly. The most important question is whether one of them yield statistically more live birth rate at the end of the day. And actually, since the introduction of the GnRH antagonist, many meta-analyses and review articles appear in the literature trying to compare these two protocols. And I will only get over the Alinani-Cochrane reviews, and you can see starting in 2001, in the first review, consisting of 5 studies, it demonstrated that there was a significantly higher clinical pregnancy rate using the agonist protocol. Same trend in the 2008 review, significantly higher ongoing and live birth rate using the agonist protocol, and the difference was about 4.4%. And somehow, in the 2011 review, consisting of 45 randomized controlled trials, there was no more statistically significant difference in live birth rate or ongoing live birth rate, pregnancy rate. The significance was only when they looked at clinical pregnancy rate. And the question is whether this is true. Now, if you are looking at the studies that are included in the live birth rate table, and you take a closer look at this study, you can see that actually they included study with unacceptable pregnancy rate. Like the study of Marcy, pregnancy rate in the agonist group was 0, meaning that they actually include studies that treated probably elderly, poor responder patients. Moreover, they also included study that used minimal stimulation, that actually did not utilize the advantage of the long GnRH agonist protocol that yield the vigorous stimulation more oocyte. So we believe that just being a randomized control study does not mean that it should be included in this meta-analysis. And we did a reanalysis of this meta-analysis or Cochrane review after excluding the studies with unacceptable low pregnancy rate and minimal stimulation. As you can see, the reanalysis revealed that the long GnRH agonist yield a significantly higher live birth rate, and we did the same exercise on ongoing pregnancy rate. Again, there was a significantly higher ongoing pregnancy rate using the agonist compared to the antagonist. So actually, in terms of pregnancy and live birth rate, the antagonist protocol is the preferred protocol to our opinion, and as I showed you. Now, what about safety? So when you're speaking about safety, so there is a consensus that using the antagonist protocol revealed less prevalence of OHSS, and here is the Kolibianakis meta-analysis showing that, I will go back. There is back. I don't know. So Kolibianakis meta-analysis showed that it's actually there is 50% lower chance to be hospitalized due to severe OHSS using the antagonist. So the antagonist is actually a safer protocol, and we have now a problem. In one hand, we have more pregnancy rate using the long protocol. In the other end, we had the antagonist is more safe. So what should we do? So already in 2005, we published this flowchart that actually we suggested to offer normal high responder patient that attend your program for the first attempt, the degenerate antagonist protocol. So if they will hyper-response or response vigorously, you can always substitute the HCG trigger with the GnRH agonist trigger, and by doing so, you can actually eliminate the occurrence of OHSS. OHSS, as you all know, the pathophysiology is not well understood, and there is actually no reliable prediction test. And when we try to predict OHSS, so there are all these risk factors or conditions that are associated with increased prevalence of OHSS. But if you take all these risk factors together, at the end of the day, the detection rate of severe OHSS in high-risk patients, according to the previously shown condition, are only 20%. What about the cutoff, the E2 level, the peak E2 level, and number of oocytes? So already in 1991, Ricardo Ash published this study showing that you need an E2 level of higher than 6,000 picogram and more than 30 oocytes. These figures are associated with 80% chance of developing severe OHSS. And this was in the time of the long agonist era. There was no antagonist in 1991. What about these figures using the antagonist? So everybody is quoting a Papanikolaou study from Bristol. They looked at their data, 2 years, 2,000 cycle of antagonist, and as you can see, E2 of 2,500 and more than 13 follicles, 11 millimeter in diameter. This is following a ROC analysis. These two cutoff could predict severe and moderate, early and late OHSS with this sensitivity and specificity, which are not so high. And when they consider only severe OHSS, you can see that actually they got the same figure as Ricardo Ash, 5,000 picomole and more than 18 oocytes, with a higher sensitivity and specificity for severe OHSS. So I consider that 5,000 as the real cutoff, and I consider the 2,500 as the soft criteria to predict OHSS, and I will come to it later, and you'll see it. How do we prevent OHSS? So here is the list of all the measures to prevent OHSS. There are good measures for those who are stimulating with the long protocol, but since the introduction of the antagonist protocol, the main measure is using the antagonist with the agonist trigger. By doing so, we actually eliminate OHSS, but there is a problem. If you are triggering final follicular maturation with the GnRH antagonist, so you actually end with lower pregnancy rate and higher miscarriage rate. And this is the meta-analysis by Grissinger. But if you are looking at the studies included, most of the patients in these studies are normal responders, not patients at risk to develop OHSS. And the question is whether you are triggering high-risk patient with the GnRH agonist, is still pregnancy rate is lower and miscarriage rate is higher. We tried to conduct such a study, prospective study. We applied to our RIB, but we didn't get their approval because by doing this study, you actually putting your patient in 20%, the control group in 20% risk to develop severe OHSS. So we decided to look at our data retrospectively, and we compared 3 groups of patients, those treated with the agonist that were at high risk to develop OHSS. You can see their E2 level and number of oocytes. Those treated with the antagonist with the agonist trigger, again, E2 level number of oocytes, and normal responder treated with the antagonist and agonist trigger. And as you can see, we actually demonstrate that implantation rate was significantly lower in those triggered with the agonist in this high-risk group patient. And then, in the meantime, 2 years later, somehow in the state, Engman got the approval to do a study comparing the long GnRH agonist protocol with HCG to the antagonist with agonist trigger. And here you can see the randomized patient to the agonist with HCG trigger and antagonist with GnRH agonist trigger. All the patients receive an intense luteal support. They received estradiol and progesterone in oil, and the dose was adjusted according to the progesterone and estradiol level in the mid-luteal phase. And by adding this intense luteal support to the agonist trigger, they actually overcome the detrimental effect of the GnRH agonist, but as expected, 15%, actually 20% of the patients in the control group develop severe OHSS. So after seeing this study, we started to intensely support our patient in the luteal phase, and then we compared our data in patients that were intensely supported to the historical cohort data that I just showed you the publication, and then you can see actually we could not demonstrate any improvement in clinical pregnancy rate. The clinical pregnancy rate in our end in patient triggered with GnRH agonist without HCG is about 15%. There was a slight increase in the implantation rate, but it didn't reach a statistical significance. Following this option or measure to try to overcome the detrimental effect of the agonist, Umedian came with his suggestion, and Umedian's suggestion was to add a small bolus of HCG, 1,500 units, on the day of oocyte retrieval. And by doing so, he actually believed that he's rescuing the luteal phase of the corpus luteum and can overcome the detrimental effect of the agonist trigger. In these nice prospective studies, you can see they randomized patients to the GnRH agonist trigger with small bolus of HCG on day of OPU to patients that were triggered with HCG. And you can see that actually a pregnancy rate, clinical and ongoing, were comparable. But if you're looking at this patient, you can see that 8 or 9 oocytes were retrieved. So meaning that they're actually randomized patients that are not at risk to develop OHSS. So in these cases, the addition of 1,500 units of HCG overcome the detrimental effect, but we don't know if it will actually prevent OHSS in patients at real risk. So they understood, and this is why they conducted this following study. And in this study, they looked at patients at risk and patients not at risk to develop OHSS. It was a multi-center, multi-international study. And again, each of this group were randomized either to the GnRH agonist trigger with a small bolus of HCG on the day of pickup or HCG. You can see that they used actually the soft criteria. Patients at risk to develop OHSS were not patients with E2 higher than 5,000 and more than 18 oocytes, but patients with more than 13 or 14 oocytes, 11 millimeter in diameter or more. So that's the soft criteria of Papa Nicola. And when they looked at their data, so you can see that actually they could overcome the detrimental effect of the agonist. Pregnancy rates were comparable between those who were triggered with GnRH agonist and those who were treated with HCG. And when you're looking at the prevalence of OHSS, you can see that those triggered with HCG, the incidence or prevalence of OHSS was 3%, which is much, much, much lower than the expected 20% in a high-risk group. And as you can see, so they were not the real high-risk patient to develop OHSS. Surprisingly, in the low-risk group that were also randomized to the agonist and the HCG group, those that were triggered with agonist develop OHSS. My father used to do both. Okay. In the meantime, there is this review appeared, Shachar Kol and Peter Remedian, and describe all the development with the GnRH agonist trigger. They mentioned their study that I just showed with the high-risk patient. And in this review, they concluded that, or suggested that if patients have more than 25 follicles, 11 millimeter in diameter or more, so in this patient, you should avoid the small bolus of HCG, and you better offer them the intense support or the freeze-off policy. Now let's see what's happened. In the same year, a publication from a Canadian-Turkish group that actually present their real-life, real clinical practice using the Umedian protocol in high-risk group patient. And as you can see, they use this protocol, the agonist trigger with the addition of the 1,500 unit of HCG. 5 of the 23 patients develop OHSS, 20%. Meaning that actually you are giving the agonist trigger to eliminate OHSS. And if you are adding this 1,500 unit of HCG on day of OPU, all this preventive effect abolished, finished. Okay? So that's the same expected 20% of severe OHSS in high-risk group patients. So it's a problem. Now, if you're looking at the patient that develop OHSS in Saihan group, you can see that 4 out of these 5 patients had less than 25 follicles, meaning that they are in the safe range of a number of follicles that you can offer that 1,500 unit of HCG. So we actually have a problem. So what do we offer? So as you all know, there are 2 forms of OHSS, the early and the late form. And the late form occur 3 to 7 days following the HCG trigger. So we believe that we should delay the HCG bolus and give it not on the day of OPU, but you should wait 3, 4, 5 days until the day of transfer. Look at this patient, this is the time that coincided with the end of the early onset OHSS. Evaluate the patient on the day of transfer. If the patient have no signs of moderate OHSS, so this patient you can add this small bolus of HCG. Otherwise, if she has large ovaries, a fluid in the pouch of Douglas, so this patient we can either freeze all or offer them the intense support with the notion that their pregnancy rate will be reduced and the miscarriage rate will be higher. The problem with this suggestion that we wondered if this delay, the 3-day delay in HCG, will still rescue the corpus luteum. Maybe it's too late. So we did this proof of concept study. The first author is Yigal Lass, he's sitting there behind. And as you can see, high-risk group patient triggered with both of them triggered with GnRH agonist, intense luteal support, and those that during evaluation on day of transfer had no sign of OHSS, we added the 1,500 unit of HCG, the one with larger ovaries, fluids, so we gave them only the intense support. You can see the E2 level in picomole, number of oocyte retrieved, and you can see that the progesterone, mid-luteal progesterone level on those who received the 1,500 was actually above 127. So we could rescue the luteal fast by adding the 1,500 unit on the day of transfer. And if you are looking, you can see that again, when we are triggering with GnRH agonists without any HCG, we are always getting the same clinical pregnancy rate, about 15%. So when with HCG, we can get a higher clinical pregnancy rate. So since this observation, we actually updated our flow chart, and now a patient attending our unit with normal high that are normal high responding the first time, we're offering the antagonist protocol if they are not at risk to develop OHSS. so they are triggered with HCG. If they are at risk to develop according to, this is the SRM criteria, so we are triggered them with the agonist. If they yield more than 20 oocytes, so we offer them the freezole, or if they insist on a transfer, so we transfer with intense support. If they yield less than 20 oocytes, so we start with the intense support, we follow the patient, evaluate them on day 3 of transfer. If there is no sign of OHSS, so we transfer with the addition of 1500 HCG bolus. If they have a sign, so we either freezole or again transfer with intense support with the notion that pregnancy rate will be reduced and miscarriage rate will be higher. Otherwise, we actually individually tailor the COH protocol, and as you can see, since we believe that the agonist is better than antagonist, so that would be the preferred protocol. So the next question, I have 15 more minutes. 5 minutes? So I will try to do it quick. So the next question, or the last question, is whether we should trigger, whether GnRH agonist trigger should be offered to all or only to high responder patients. So we know that during the natural cycle, there is a mid-cycle LH and the FSH peak, while during the stimulated cycle, there is this increase in FSH and then actually the HCG trigger. And the question is what is the role of this hormone, the LH, the HCG, and the FSH? Now you can see that when we are activating the LH receptor, we're actually activating several downstream cascades responsible for steroidogenesis and for oocyte maturation and granulosa cell maturation. And the question is whether when LH or HCG bind to the receptor, they're activating the same cascade. So this was nicely demonstrated by Simone's group in granulosa cell culture with an LH and with HCG. And as you can see, when LH bind to the receptor, it activates mostly the cascade responsible for maturation. And when HCG binds to the receptor, it activates mostly cascades that are responsible for steroidogenesis. This was also shown in vivo. In our study, we looked at the granulosa cell gene expression in patients that were triggered with HCG and those that were triggered with HCG and GnOH. And as you can see, I don't know how to take it back, but as you could see, the genes that are responsible for maturation were expressed higher in those that received the GnOH. The GnOH, okay. So as you can see, genes that are responsible for maturation were highly expressed in following the GnOH agonist and HCG compared to the HCG trigger. Now, what about the mid-FSH peak that you can see following the GnOH agonist trigger or the natural cycle, but not during a HCG trigger? So this was nicely studied by a LAMP group. They trigger a patient undergoing the long protocol with either HCG or HCG with 450 units of FSH. And you can see that those that received the 550 units of FSH, the additional 500 units, had more oocyte recovery rate and higher fertilization rate. So it actually confirming what was already known, that the FSH has a role in promoting formation of LH receptor, nuclear maturation, and cumulus expansion. Now we know that the LH surge is responsible for resumption of oocyte meiosis, follicular rupture, and oocyte expansion luteinization. HCG is doing the same, but increase the risk of OHSS. The GnOH trigger is doing the same without OHSS. And the question is whether HCG and GnRH agonists are doing the same with regard to the number of oocytes or the percentage of mature oocyte. So this issue was studied in several studies. As you can see here, actually, when we are looking at the embryological parameter, the GnRH agonist trigger is doing as good as the HCG, even better. Okay? And this is what actually led this group to try to compare. It was a quasi-randomized study in normal responder. They compared the HCG trigger, full dose of HCG, to HCG and GnRH agonist trigger, administered 36 hours before OPU. And then you can see the addition of, now is the addition of GnRH agonist to HCG, revealed higher number of oocytes, higher number of mature oocytes, and higher number of top quality embryos with higher number of percentage of live births. So this dual trigger, the HCG and the GnRH agonist, yield actually a better outcome compared to HCG alone in normal responders. A Griffin group, Engman, used this protocol in patients with more than 25% of immature oocytes. And as you can see, the addition of GnRH agonist to HCG yield a higher number of oocyte reservoir, mature oocyte, and percentage of mature oocyte without affecting the pregnancy rate, and they related it to the underlying oocyte dysfunction of this patient. And this group from Bristol, again, compared in normal responder the HCG trigger with the dual trigger, couldn't find any difference in the number of M2 oocytes or the cumulus COC complex, but in the dual trigger, there were more patients with at least one top quality oocyte and more patients with embryo for cryopreservation. And now in 2000, and I'm going to finish with 3 slides, in 2012, this case report appeared in the literature showing that presenting a patient with repeated empty follicle syndrome, despite a very nice hormonal and ultrasonographic response, they offered this patient what they call the double trigger GnRH agonist, decapeptyl 0.2, 40 hours before OPU, and HT 34 hours before OPU. And the advantage of this double trigger was actually prolongation of the time between the trigger and the OPU, leaving more time for maturation, and adding the GnRH agonist so that we have a mid-cycle LH, mid-cycle FSH, and mid-cycle HCG. Actually, hold the benefit of all the hormone in one cycle. So after seeing this case report, we said, okay, if it's working in this empty follicle, it might work in other conditions with impaired final follicular maturation. So we started to offer this protocol to patients with low number of oocytes per number of dominant follicle. And when we offer this patient this double trigger, 40 and 34 hours before, there you can see that actually all the embryological parameters were improved. More oocytes, more mature oocytes, more embryos, and more top quality embryo. Then we offered this double trigger to patients with another problem with the final follicular maturation, those with high proportion or percentage of immature oocytes. More than a third of the oocytes were immature, and again, you could demonstrate a significant improvement in all the parameters of the embryological parameters. So what we are doing today, we're actually tailoring the protocol, but we are more concentrating in tailoring the trigger of final follicular maturation. In high responders, we are triggering them with the GnRH agonist and evaluating them on day 3 post-OPU, on day of transfer. And if there's no sign of OHSS, we can add this 1,500 units of HCG. Normal responder, we trigger them with dual trigger HCG and GnRH agonist 36 hours prior to OPU. Those with abnormal oocyte maturation, we are triggering them with the agonist 40 hours and the HCG 34 hours. And here are the preliminary reports or experience. We didn't report it yet, but in poor responders, we're actually offering the dual trigger 34 hours before the retrieval in cases that we reach the end of the stimulation with follicles more than 18 millimeter. And those with, if we get to the patient with follicle of 15, 16 millimeter, so we offer them the double trigger, and with the double trigger, we actually retrieve mature oocytes also from follicle 12, 13, and 40 millimeter in diameter. That's it. Thank you.